Today my topic is midterm outcomes of K-clip transcatheter tricuspid angioplasty system in patients with severe functional tricuspid regurgitation, research findings from Tristar study. My content includes 5 parts: background, anatomy, the system, research findings, and conclusion. Let's start with background. We know severe tricuspid regurgitation significantly impacting life quality and increased mortality, and about 4% of the elder are affected by the TR. And the traditional treatments, including surgery or medicine, face a lot of challenges and with high mortality, about 10% of the surgical death rate. And the recent transcatheter interventions trials show promising results. Many patients with TR are excluded from the trial, if you have read about the article, due to its stringent inclusion criteria. And these patients with complex anatomical challenges are disqualified from potential beneficial treatment. And then the K-clip system requires minimal anatomical alternation of the TV and is easy to use, and offers a very short learning curve. And I will show you in the next slide. And the K-clip design promises to extend the benefit of transcatheter TV intervention to a broader patient population. And we know that 2025 ESC guideline has updated the recommendation on secondary tricuspid regurgitation, and our paper was just published before the guideline, so it was not not included in the guideline. It's very close. And this is the anatomy. We can see the tricuspid annulus is very close to the right coronary artery. So it's very important in the procedure of K-clip. And this is the K-clip system. We used you can see the video. We used the jugular vein to approach the place, and we do the surgery or do the procedure under the guidance of TE and the DSA. And the device will be just stay in the right atrium. We don't need to close the valve, and we don't need to go to the ventricle. And first we find the landing zoom, and the screw will just into the annulus, and the clip will closed, and the annulus will be reduced, and also the TR. This is the key structure of the device, include ankle screw and the clip arm and the steerable implant catheter. And I draw a figure to let you understand the basic principle of this device. We just to reduce the size of the annulus and reduce the gap. Now let's back to the Tristar study. The figure is included design and the 1-year outcome. The Tristar study was registered in the clinical trial with the NCT, and it was invested 1-year outcomes of the K-clip transcatheter tricuspid angioplasty system in severe TR. And a patient with TR grade more than or equal to 4, and resistant to medical management. And this kind of patient were enrolled and selected by core lab, and oversight by a data safety monitoring board and event adjustment by a clinical event committee occurred. And assessment at 30 days, 6 months, and 1 year included echo date, clinical symptoms, quality of life, study endpoints, and major adverse events. You can see we screened about 112 patients, and finally 96 patients were enrolled. And after a 1-year follow-up, 5 patients died, and excited or failed implantation number was 2, and the 3 patients missed the visit. So the final result is all-cause mortality is 5.2%, and composite major adverse event was about 20%, and heart failure hospitalization rate was about 9.4%. And the 6-minute walk distance increased about 43 minutes, and the KCCQ improved about 5 points. This is the basic characteristic of the patients. We can see the mean age of about 73, and about 60% of the patients was female, and all patients has GR grade more than 4, and some patient has severe tethering about more than 10 millimeter, and all the patients were secondary TR with the mean Euroscore 7.7 and tri-score of 6. And some of the patients had received previous cardiac surgery, including mitral valve surgery, aortic valve surgery, TV surgery, no TV surgery, and some of the patients had received the CABG before, and one patient received the pacemaker leadless. And some patients have some comorbidities, including hypertension, diabetes mellitus, and atrial fibrillation, and so on. And let's look at the procedure characteristics and the clinical success. We can see the successful implantation rate was about 97.9%, and the procedure success was about 92%, and the clinical success was about 86%. And the mean surgery time was about 2 hours and 2.5 hours. A device time about 55 minutes. We use the echo to evaluate the anatomical distribution of the secondary TR. We can see most of the TR was from central, and then the anterior and septal commissure. And the most common size of K clips was 16 and 14. And most of patients received 1 or 2 clips to solve the problem. And the most common the K clip location was in the post-septal commissure, and then the anterior posterior commissure. TR reduction at procedure the result was good. Most of patients reduction reached 2 or 3 grade. And this table shows the CEC adjusted major adverse event at 30 days, 6 months, and 1 year. And you can see nobody was died in the 1 year follow-up, and only 1 patient received open heart surgery. And bleeding was the most common adverse. The composite major adverse event was about 20% at 1 year follow-up. And you can see the right coronary artery stenosis was quite common. About 17 patients has got stenosis, but it was lucky that no patient will receive needs require intervention. And the all-cause mortality was 5.2%. And the KM estimates that at 1 year demonstrated about 95% survival and 90% freedom from heart failure rehospitalization. And the right side figure shows 64.6% relative reduction in 1 year heart failure rehospitalization. Now this slide shows the K-curve system with echographic and clinical outcomes. Figure A shows TR severity was significantly reduced from baseline to 1 year post-procedure. And B shows the sustained TR reduction of at least 1 grade, and it was evident at 30 days, 6 months, and 1 year. with a rate of more than 90%, respectively. And the C2E shows the significant improvements in New York Heart Association function and the KCCQ score and the 6-minute walk distance. And the left and the right ventricle function improvement also can see in on the echo data. At 1 year, cardiac ultrasound indicates significant improvements in LV and diastolic volume and CO. RV remodeling was evident with reductions in septal later TV annulus diameter and RV and diastolic diameter following the K-clip procedure. And when talk about the landing protocol, this is very important. We use the Flow CT software to evaluate the potential landing protocol or potential landing place. You can see this place about the anterior posterior septal commissure. The distance between the annulus and the right coronary artery was quite good. And this place is about in the middle of the posterior leaflet. This place, the distance is quite short. And our analysis, the 96 patients, we can see the mean post-septal commissure distance is about 15 millimeter. And the midpoint of posterior leaflet is about only 6.3 millimeter. And the anterior posterior commissure was about 8.5 millimeter. So we can say the posterior septal commissure was a very safe place for K-clip procedure. And the red one is quite dangerous. That may cause the stenosis of the right coronary artery. And here's a case shows the basic procedure of the K-clip. It's a 85-year-old female with a functional TR, a grade 4. The regurgitation jet mainly originates from the central, and the leaflet tethering is mild, and the right ventricular function is normal. We can see the TR. And this is the landing protocol for the K-clip. First, we just deliver the system, enter the right atrium over the SVC under the guidance of TE. Then we use 3D to adjust the direction of the delivery system to the target position of just the landing zone. Third step is insert the anchoring component with the multi-view. Then the fourth step is open the grasping arms. You can see this is the arm. Then the grasping arms adhere to the annulus. The last step was to close the grasping arm and evaluate by the echo. The result is good. The reduction, the TR was decreased from 4 to 1 grade, and the leaflet promised improvement, and the TV area reduced about 26%, and the right coronary artery was also very good, no noises. Now here comes to the conclusion. The 1-year outcomes from the multi-center Tristar study validate the K-clip system, and it's a safe and effective option for severe TR. It demonstrates significant TR reduction, low MAE, decreased heart failure rehospitalization, improved RV remodeling, and enhanced the cardiac function and patient quality of life. The short-term and mid-term result was published in JCC Advanced and JCC Cardiovascular Interventions. And it was lucky the robotic hand and the MyVo Alaskan gave us the comment for the K-clips, as they believe it was a potential device to treat the severe TR. Thank you.